And if you put them all together, you have 8. And this line is the area that we're comparing with nothing. To the left is less and less % chance of dying in over 6 months survival in this particular study. So if you can get down to here, the likelihood of mortality has been reduced by 50%. And each of these goes a little to the left, 10%, 20%, 30%, or 50%. So that's it. Thank you very much. I appreciate that. Then I have to ask our boss if we have time for questions. Patty, do we have questions? Time for questions?
Absolutely. I think we want the lights to go up so we can have an interactive discussion.
Absolutely.
There we go.
So this is very, if you present this at any medical meeting, there's lots of debate and discussion because some of these things are new, they're evolving, and people want to know about it. Did you have a question? No? Okay. Yes, ma'am. Next.
Do you have documentation on labor, the kind of job that people do, jobs, and hearts?
Is there documentation and data on occupation and heart attack?
Yes.
That's a huge topic. There's nothing new or controversial on that. Stress, it's more stress than the type of job. So the job and stress kind of go together. And stress is clearly implicated in recurrent heart attacks and heart attack. We know stress is a huge risk factor. The problem is whether it's job-related stress, family-related stress, personal issues. The problem with stress is we can't measure it. We can say, oh, this guy's under a lot of stress. Getting a promotion is stress, right? It's good, but it's stressful because now there are different expectations. Marriage is a big stress factor. Probably don't have to convince too many people. We give up our autonomy, but we trade it for something much better. But it is stressful. So we can't measure it. With cholesterol, we measure it. And we can draw graphs that the higher it is, the higher the risk of a heart attack. So stress, absolutely, it's more and more recognized in good rehabilitation programs. There are behaviorists who identify these people and can help just themselves or referring the patient to even more intensive counseling or psychiatry, psychology. Absolutely.
Do you see any numbers higher in certain occupations like, let's say, construction, farm work, farm workers?
Well, the construction, farm work particularly goes with socioeconomic status. And the lower the socioeconomic status, the higher the stress level. Being a person of color, female, with all the responsibilities and trying to be superwoman, those are all tremendously stressful. Now, construction, there are countervailing factors there. Being a construction worker and being laid off, like in a depression, is incredible stress. And then when one comes back to the job, one has the stresses of the job, but now has the security of the job. So it's very tricky in those cases. But the lower the pay, the higher, and the socioeconomic status, the higher the stress. It's interesting that African Americans, or we can say black people, they come from the Caribbean, where they are in charge of the country. And then they come to America. That population of blacks doesn't have the same high rate of cardiovascular disease as the African Americans who have been here for centuries and came out of slavery. It's totally different. The success rate is incredible. Sidney Poitier is one. Ralph Bunche, who used to be our representative way, way back to the original United Nations, is another. The success rate in college graduation rate in that population is amazing. They don't have the hypertension that the blacks in this country have. So being here and under the misery that has been caused from slavery and Jim Crow, and voter suppression. Those are all tremendous stress factors. I don't have numbers on that, but it's very clear. Those populations are really different. So it's not just color. It's color in America. It's brown, it's black, it's female, it's impoverished, single moms. Those are all extremely stressful. We can't measure it, though. There are scales. We try, and we relate it to what you're talking about. It's well known. Tough to deal. She was second, and yes, ma'am. Yes.
I had two questions. One was just to follow up on your last slide, where you showed you know,
8.
2 therapies, 3, 4, 5, 6, 7, 8.
Yeah.
Was each one relating to specific therapies, or just if you do any of the, like 8 recommended therapies?
That is, did everybody hear that? That last slide that showed 1, 2 to 8 therapies, are they specific therapies? They are, but the number 1 could have been one of many. So it could have been aspirin, it could have been a beta blocker. It's if you do one thing, right? And we'll assume that aspirin is the one that's one because that's given to 90% of people. Some people bleed or they're allergic to it, so aspirin is out. As you go away from aspirin, the beta blockers, statins, those are good. Those are up in the 80%, and then we get lower and lower. I didn't mention the drugs like aspirin. So easy to get 8 because we say to a person who has a stent that we use dual antiplatelet therapy. So aspirin is one to keep those platelets behaving and not clumping. Aspirin is one, and then there are the newer antiplatelet drugs. So that's 2. So dual antiplatelet therapy, very important.
My second question is, given the high relationship of stress to the disease, what do you know about the effect of meditation?
Meditation. Given the stress in relation to the disease, to coronary disease, what do I know about meditation? I know that meditation and yoga both are beneficial in reducing stress. There is a paper, and I don't know where it went, from more than 10 years ago, in a very good journal. It's a journal of the American Heart Association. It's not Circulation. It may be, it's a journal of neurology, but it's not a bogus journal. It's a very good journal. And a study was done on atherosclerosis in the carotid arteries of black men. And they had a control group. It was prospective. They were carefully, this is very controversial, measuring the thickness of this artery. And they were looking at plaques, actually. And you have to be very expert at that and do it all the time. And the study went on for several years, and the men were practicing meditation. And the guys that were doing meditation had some reversal, some mostly stability, and the other guys that were getting everything but meditation, their plaques were progressing, thickening, getting bigger. That's where strokes come from, rupturing the plaques in the carotid arteries. It works. It has to be really done. It should be done right. And it's a wonderful thing, absolutely wonderful thing. I wish I could do it. But I have monkey mind. I can't. But my daughter says, that's okay, Dad. Just come back to your breath. So, and there is a psychologist who visited the Med Center a couple of years ago, forgot his name, but he advocates, to begin with, the 1-minute meditation, the 1-minute meditation, and then he builds you up. But 1 minute can lead to more minutes. So, good points on stress. Yes? Yeah, you.
What do you think about refined sugars, artery inflammation?
Refined sugars, what do I think?
Yeah, I'm seeing
I
more of
think,
that.
and this is not my field, and I can't give you data, but to me, refined sugars are poison. They are highly pro-inflammatory. And now the watchword in cardiology is inflammation. Everything is due to inflammation. Back in the 90s, it was plaque stability. It's still plaque stability, but inflammation is one of the factors, maybe a major factor that makes those plaques rupture. So refined sugars, candy, all those things, those goodies, terrible. And we can live without them, and we will live without them. Without them, we will live. With them, not so good. It's a great question. Yes, you look familiar.
Yeah, I met you a couple weeks ago at AHA.
At AHA?
Yeah, Jane Fuller, nice to see
Oh,
you.
yeah, nice to see you. I didn't shake your hands, ladies, because I didn't know you would. All right, yes.
So I'm tying the two conversations together, the calcium score, I've been kind of sorting out in my mind where the calcium score falls. The 2014 guidelines did not raise it to the level of, something that would give. that you would
Recommendation, we didn't do a
recommend,
recommendation on it.
yeah. Right.
We
so-
did on CPA. We did, in the chest pain unit, even though we don't use it, it got the best rating of the tests.
Okay.
And we didn't do calcium score, but it has really come up now. They change, very continual evolution.
So in my mind, the calcium score has always been if somebody's at intermediate risk and they're on the fence.
That was one of, did everybody hear that? In his mind, the calcium score has been something that's used if you're intermediate risk by, it used to be the Framingham risk score. Now it's the arteriosclerotic cardiovascular disease risk score. You can do it on your phone, even if you put it into Google, it'll come up and you can fill in your blood pressure, male, female, white, and you will get your 10-year risk for a cardiac event, fatal or non-fatal MI, and stroke. It also will tell stroke. So intermediate risk, and that was good was under 10%. Intermediate was 11 to 19%. 20% and higher was very high, and take action. Under 10% was pretty good. Do what you've been doing, and then the intermediate was, it told you stop smoking if you smoke, get your blood pressure taken care of. And one of the things, of the many things that could refine the intermediate risk was calcium scoring. Looking at C-reactive protein for a measure of inflammation was another one. Family history is not in the things that you look at on these risk scores because it doesn't work. It's so important, but it's so poorly done by us. I mean, a patient may have a history done at 3 a.m., the intern with his 15th admission. Yeah, you're in any family history? Oh, yeah, aunt? Okay, family history. That's not a family history. We want a family history of, that was supposed to be funny. Family history, premature atherosclerotic disease, evidence of, not the person had high blood pressure. That's not a premature history of coronary disease. It is a heart attack, a sudden death. That's a premature history of cardiac disease. Now a stroke. So then you put that in. It's unclear how you put it in. If your risk is 7 or 8%, you put it in. If that was I would put myself up to over 10. Or if I was 15, I'd put myself at 20. You can work that out with your doc. That's unclear.
Okay.
So,
But, yes.
Dr. Bomber prepared a couple of slides to
Oh.
further the inquiry.
Quick question for you first is, we're now, this year, in the introduction of high sensitivity troponin. And we're all going to have it in our ERs in Sacramento. It's available right now and we'll be dealing with it. Do you see that making a change in your algorithm for the chest pain units? Because potentially we could detect lower risk patients. Are we going to have more patients, fewer patients, better diagnosis with the high sensitivity era?
Yeah, Bill is right. That high sensitivity troponin is 100 times more sensitive than the one we use now. And it's been used very successfully in Europe and in New Zealand and Southeast Asia. And they do what they can do the 1 hour rule out. They don't do treadmills, they don't do any of these things. If the patient is stable and they put a couple of factors on, it doesn't have risk factors, they look at that, and then they get a high sensitivity troponin and it's normal, then, and it's more than 1 hour, it's had time to go up. They'll discharge the patient, and they follow them up at 30 days, and they have over a 99% negative predictive value. At 30 days, maybe 1 or 2 patients out of 500 or 1,000 have had an event, and they've come back in, and they've been taken care of. The house staff, the residents, and some others of us are very concerned because, as Bill said, it's so sensitive. The definition, this is an interesting one. The definition of the high sensitivity troponin says that it is abnormal, that's a dangerous word to say, but it's elevated in 50% of normal people walking around. It's elevated, not to the point of a myocardial infarction, but it's elevated. And that means the patient has to stay and get some more tests. And so what you'd hope is it's just flat. And then that person, depending on the individual patient and physician judgment, will then have to go on and have a further workup. But that's quite something. You know, they use the 99th percentile, and if you're of the population, and if your troponin is over the 99th, that means 99 out of every 100 people in your population, that this is higher than 99, you're the one of that 100 that's over that. Now we're suspicious and we start drawing more. But what it may tell us is what we consider normal, it's picking up, it's a risk factor downstream. If it's low elevated, then in 6 months or 6 years, nobody knows at this point, it's a risk factor, something's going on, because that comes from heart muscle. And if it's elevated above the 99th percentile, then we're going to be going crazy. There are going to be a lot of people admitted who don't have anything, at least obviously wrong with them. They should be watched carefully. It's opening up all kinds of things. But when it's negative, really negative, 1 hour, 2 hours, or 3 hours, each hospital will decide how it's going to do this. We probably won't stop for a while doing our tests, our treadmill or nuclear, or other people will be doing CTA or coronary calcium in that setting. Everybody has their own favorite test. The same thing is happening with high blood pressure. In the new hypertension guidelines, it should be noted if you're over 120 over 80. Note it and be watched. If it's over 135, you have hypertension. No more 140/90. That's a change from 2013 and 14, a couple of years. And that's on more data. So it drives lay people crazy. My friends say, you guys can't make up your mind. 1 minute you're telling us women to take hormone therapy, and then you say no. And I try to explain it's based on the evidence, the evolving evidence that keeps pouring out all the time.
Dr. Best, did you have a question?
No, I don't have a question.
I don't know, Bill, what we're going to do. We're going to keep doing what we're doing and compare. That's one thing we're doing on the slide. Not on the slide, it's done blind. We keep the blood. And we're going to look at what the high sensitivity, how that compares to the management of the patient with the contemporary. The one we have now is not a slacker. It's the 5th generation. Keep making it better and better. We're going to
So based on what you said before, if you had a positive reading on the supersensitive troponin and you had a negative coronary calcium score, then
those happen. Those things happen because we have all these tests. So a negative calcium score, you mean 0?
yeah.
0. That's good. So there may be something else percolating that's not related to coronary disease. Maybe the person has hypertension or has kidney disease. Kidney disease is a major source of inflammation, and it may be picking away at the myocytes, the cardiac muscle cells, and the troponin goes up. That's a great question. Thanks for telling us what we're going to be struggling with.
Well, so it's just a matter of triage, right?
Sure.
And Bill had another question
Last
before.
question, then we'll let you go. If we look at the chest pain ER unit, and we look at the patient who is low risk, troponin negative, EKG negative at that point, they often spin down to a decision of whether to do a, quote, confirmatory test or not.
That's right.
Most of those in the past have been functional tests, but the CT angio and the CT coronary calcium score are more anatomical tests.
That's it. Yes.
Do you see the trend going to, because functional tests really are only going to identify those with greater than 50 or 70%.
With a critical lesion. Critical
But the
lesion.
anatomical test might detect less.
Yes.
And we know
Yes,
that less could rupture.
Absolutely.
Now, a lot of your data was 30 days, so 30
That's
days,
right.
yeah, a functional test is going to be
That's
very
right.
helpful for that.
yes,
But if we
Yes.
look at 1 year
yeah.
and 10 years
Yes.
out, maybe functional data wouldn't provide as
No.
good as anatomical data of calcium.
That
in
is
the
true.
coronary.
Yet, that is a very interesting question, and you're smarter than I am and maybe can answer it. And that is, what Bill says is right. To get a positive treadmill test, or a nuclear, or a stress echo, those are functional tests. Things have to go wrong transiently, under supervision, it's all controlled, and then they reverse right back. I mean, those are the tests we use. And you need a tight lesion. And yet, and it doesn't show you the lesser lesions. And yet, the warranty of those tests is fantastic. It's way beyond what it should be based on that. I mean, a good stress test with a high METS functional capacity and no ischemia on the treadmill, et cetera, those things are excellent downstream. So they miss the lesions that are not critical, but somehow they're also identifying that those lesions are stable. I don't know. It's an anomaly to me, because what you say is absolutely right. We should be getting events in those people. And they're not 100%, and it could be in those. But people decry the treadmill, and say, oh, it misses 30%. It does. It has a false negative rate of 30%. It misses coronary disease at 30%. But it still has a great prognostic value. So, yes.
So I have a question. You were saying about with the guidelines and intermediate risk. So, and thank you so much for your talk. The app that you were talking about, that somebody can go on and they can check out what their risk factors are, right? And 10-year risk or 20-year risk. And I believe in the American Heart Association guidelines for intermediate risk that calcium score plays a component as far as identifying disease early. Just wondering if you could touch on it, because that's my thing as far as how, it's great that we have these protocols when somebody comes in the hospital, but what about these patients that aren't quite there yet?
Yeah.
And how do we get them to not even get there?
Well, but if they're intermediate, that would be, one reasonable thing would be to do what calcium
Get a calcium
score, or a good family history, and I'm not being facetious. Family history very important. Or I don't do C-reactive pride. I don't think I've ever ordered one, but people do that. You could do any of those tests for the intermediate risk person. They also apply there. So the calcium score hasn't yet, in everybody's mind, superseded those tests. That's all I can say. And they're going to be those people who advocate it.
So before anybody speaks twice,
Yes.
I just want to.
It was a continuation of where I was at before. I just, in relation to
It should
what
be.
she's saying then, I was under the impression, I think I could hear.
Yeah.
I was under the impression that you were speaking more about the patients with undefined risk or low risk, because they're in that population like your husband, with various, good living, lifestyle, exercise, and what have you.
I would love that, but let's just start with the intermediate risk, because at least we know.
They're-
Let's just even
they're
start
high.
there. I mean, it's
Intermediate
not
risk-
even being used at
Yeah.
all, so.
You could look at the picture you showed, excuse me, of that man, and you could say, he probably had a big waist. I mean, he was robust. I'm assuming he was kind of
We should
round.
probably do a different photo of Dean that doesn't have the mud, because it's pretty hard to see what he looks like there.
Yeah. You could be thin and svelte and still have a very high risk profile. But my guess is that guy had several risk factors and could have gotten to work on that and use the ASCVD. This is my approach, and then really work on that, and a stress test if appropriate. And then if 6 months haven't worked, You can go further. And the answer, the retort to me is, well, why are you waiting 6 months? Look and see what he has. Then what would you do if you get a calcium score? There are, based on age, low, intermediate, and high, it could lead to intervention and stenting. And we all know stenting is wonderful, but when we have, that opens the gates to lesions being stented that shouldn't be stented, and stents are not without a risk in themselves. I mean, they're great. Where they're indicated, they're fantastic. CABG is certainly a very high risk relative to no risk, but it's wonderful where it's indicated. But stenting, the stents are not forever, and
Well, I think it also gives the patient the opportunity with their doctor. I mean, I have people that hear me speak and go and get calcium scores. I have somebody in our community, he was a 1,500. He did not get stented. He's doing some medical therapy. He's significantly has changed his diet, his lifestyle.
yes.
He's doing it. So
Yeah.
I just think it gives the patient the opportunity.
Yes, that's right. The point is that once you see it, then it really improves motivation. And the studies there have gone both ways. Not everyone works, but if they work, that's worth it. Yeah, and that's a very good point. Motivation can really help.
So where you have those high calcium score patients, have you seen regression? Like you were talking about the plant-based diet. We had Dr. Sky talk about the incredible success he's seen with his Air Force cardiology patients, talking about switching to a plant-based diet. So is it possible when you have a super high score like 1,000 or 1,500 to actually reverse the risk through lifestyle?
That's the holy grail, and we have no data that we can regress yet. But we have not gotten LDL cholesterols down where the PCSK9 are getting them. Ridiculously low. Some of the people were at a 10. We consider 130 is okay. 130 is atherogenic. Okay, under 100, that's still atherogenic. So we go for under 70. We're getting reasonable there. Mine is in the 60s. No good. I'm getting my doctor to raise my statin. And now, if I could get a PCSK9 for less than $1 million a year, I would take it.
I think
Those
it's
people were-
14,000.
Yeah, those people were at 10 and for a year and no adverse effects. We're born with an LDL cholesterol of 30. And who's growing faster than a newborn infant, cells, hormones, all of that the lipids, the cholesterol is needed for? Who's growing faster? 30. And they do great. And then you can see as the diet, as they start getting our good American diet,